So in conclusion, there were 4 randomized trials that demonstrated significant benefit of purified EPA. There were 8 randomized trials, I didn't show all 8, demonstrating plaque reduction with purified EPA, Eicosapenethyl, in the EVAPORATE trial. And there are now 19 societal and country guidelines that recommend EPA for patients with elevated triglycerides and either ASCVD or diabetes. So with that, I will stop and thank you very much for your participation. I apologize for the technical issues, but I'm hoping now we can open it up and have a very robust discussion. And I know Dr. Prabhakar and Dr. Joshi are still on, so why don't we open it up for discussion now?
Thank you very much. Thank you very much, Dr. Budoff. I mean, it was a very comprehensive presentation on the various trials having been carried out on the Eicosapenethyl. And I think there is a lot to learn from these particular studies in terms of how IPE, when combined with statins, can bring about the cardiovascular risk reduction, how one can basically prevent the first event, in ASCVD risk patients, and also basically the patients, who had undergone PCI. And they also basically have been benefited, those who had MI. And when the statin is combined with IPE, even those patients have been benefited. So basically, there are a lot of benefits, in high-risk individuals when you combine statin with IPE. And I hand over the session to Dr. Prabhakar. But before Dr. Prabhakar, you basically start interacting with Dr. Budoff, there was one basically fundamental question that came from the audience, that is it eicosapentaenoic acid or eicosapentethyl?
Sir, I think Professor Budoff, first I should congratulate Professor Budoff for very comprehensive review of the entire EPA trials. The trials which we never heard of so far, and he came up with such an excellent review of the whole thing. He not only did that, I think he went into the mechanistic studies of Mason, which I think is probably the most comprehensive mechanistic data that is available, and that slide on improving the endothelial function, stabilizing the plaque and everything are very clear. Now, your question was actually answered by Professor Budoff in his initial part, stating that eicosapentethyl gets converted into EPA inside the body. So I think that is pretty much. But
it was there on the slide.
It was actually the studies. The JELIS was done with EPA, while the REDUCE-IT and all the other trials were actually done with the purified form of that, which is Eicosapenethyl. Now, there are a lot of interesting facts in the REDUCE-IT trial, which I thought we should discuss with Professor Budoff. Professor Budoff, I think it's very interesting to note that the LDL levels were 40 to 100 only in these group of patients. And when we gave the triglyceride lowering drug of, as we call it a triglyceride lowering drug, but the reduction of triglycerides was only 18%. But the benefits were about 25%, much more than what you expect with 18% reduction in the LDL cholesterol. You can make a brief comment on that, sir.
Yeah, and there was a very nice trial in looking at trying to do the attributable risk and trying to determine where the benefit was, and they came up with about 2/3 of the benefit in REDUCE-IT and EVAPORATE, and a lot of these other trials comes from EPA levels going up. So it's not necessarily the triglyceride reduction, it's raising EPA. EPA is a stabilizing effect in the plaque. I didn't have time to go into it, but Dr. Preston Mason from Harvard has demonstrated really elegantly that the EPA, as Eicosapenethyl becomes EPA, it inserts itself in the lipids in the endothelium and stabilizes the endothelium, adding antioxidant properties and anti-inflammatory properties. So 2/3 of the benefit is EPA going up. A portion of it is triglycerides coming down, as you mentioned, and a portion of it is the anti-inflammatory effect that we see consistently across all of these different studies.
And I think that summarizes the kind of the action that this seems to be having. It seems to be having what we said as a side effect as probably the antithrombotic effect, And the antiplatelet effect is one benefit. The second benefit is probably the membrane stabilizing effect, which is probably the reason why the sudden cardiac deaths and cardiac arrests have also come down in this group of patients. You had mentioned about Mason's study, sir. Mason's study, actually, the JELIS trial, the increase in percentage of the EPA was actually 75%, while because they were basically fish eating population with a very high basal EPA levels. But in the REDUCE-IT, the increase was nearly 300%. And this percentage increase, I think, matters quite a lot. Your comment on that, sir?
Yes, absolutely. And we did see a larger benefit in REDUCE-IT than in JELIS or even RESPECT EPA. So I do think you're right. I think it's not only the achieved EPA levels, but the change from baseline. In the US, we had very low levels of EPA, like 26, and we got the average up to 145. There was a trial called STRENGTH, which used a combination EPA DHA 4 grams, the same dose, in a high-risk population that did not show the same benefit, but the EPA raising was much lower, and the achieved EPA was much lower because it's mixture between EPA and DHA. So I think it does look a lot at not only, as you mentioned, how much we raise the EPA, but also how high we get those values.
So I think the next important point you made is compared to, you mentioned in passing about the STRENGTH trial just now, but I think the STRENGTH trial used 4 grams again, but with a combination of EPA, DHA. And you had a very valid point stating that the PCSK9 levels are altered by DHA adversely. And that is possibly the reason why this happens. And what else do you have to say about these combinations? I think you must, all the trials with the EPA DHA combination have not shown benefit, while the EPA trials are the ones that seem to be showing the benefit.
And even if you break it, and even if you say I'm not a big EPA fan, or I don't believe in these EPA levels, if you look at ApoB, just the bad particles in the blood, from a cholesterol standpoint, ApoB does not go down when you use EPA plus DHA. You have a neutral effect. You lower triglycerides and raise LDL. And how can raising LDL be good for you? So DHA promotes more PCSK9 activity, and it raises LDL. And that's a very bad effect, right? It's the opposite of a PCSK9 inhibitor. It's raising PCSK9 levels. So I think it's very important to recognize, and if you look at the package inserts, at least here in the United States, of combination products, or Omicor, Lovasa, or the product used in STRENGTH, they mention LDL may go up by up to 48% if you put them on DHA products. So I think purified EPA is the way to reduce cardiovascular risk. It's not just the triglycerides, as you mentioned. It's also the inflammation. It's also the EPA that's probably plaque stabilizing and leads to the effects that we saw in the EVAPORATE trial and that the Japanese saw in the other trials with OCT and IVUS.
Now that you mentioned the other products that are available in the US, JAMA on 30th of August this year presented a paper comparing 2,800 available formulations of the fish oil supplements. And they said that most of them give wrong information.
Yeah.
This is actually published in JAMA a week ago. So last week it was not even a week. I think 30th of August it was published.
Wow, I'll have to look at that. Yeah, no, I mean, that's a huge problem. We in the United States do not regulate dietary supplements. So people can put anything in that bottle and claim it's anything. It's really terrible. And patients pay a lot of money for these supplements and they're not getting anything purified. So getting something that you know is a purified product and EPA by formulation has to be 98% pure EPA. You're getting, when it says 4 grams of Eicosapenethyl, you're getting 4 grams of Eicosapenethyl, which means you're getting 4 grams of EPA every day you take those pills.
It's very, very important point that you made, that you have to give 4 grams of EPA to get that percentage increase to show the benefits. A combination of the EPA DHA can actually be harmful, as shown in some of the other studies. Actually, when I was looking at how can these drugs be more beneficial, I think generally whenever we use statins, the reduction in the LDL is more than the reduction in the apolipoprotein B, which is actually reverse in the data that you have shown it from the REDUCE-IT trial, which actually shows a 6% reduction in LDL, while the ApoB reduction was 9%. So I think that is something that is very important. The overall reduction of ApoB, that is probably translating into clinical practice. I think that is one of the very important mechanisms that is happening. What do you say, sir?
No, absolutely. And I think that's largely driven not only by VLDL and triglycerides, but also by remnant particles. We're learning a lot that these remnants that are floating around, these kind of in-between breakdown products of LDL and VLDL, are floating around in our bloodstream, and they're not really captured by our current assays, but they go down, and we've demonstrated that remnants go down with EPA as well. So you're lowering the burden of ApoB through LDL, remnants, and triglycerides. And I think that's why ApoB goes down more than LDL as compared to the statin trials where it's only driven by LDL. So LDL goes down more than ApoB.
I'll put you into a little bit of a controversy now. Controversial issues that have been cropping up. I don't know how many of the people understood why you put up that conclusion slide with mineral oil and without mineral oil. Probably dilate it a little bit to enlighten the audience, because I'm sure it's going to crop up once we start discussing about REDUCE-IT trial. So you did it very beautifully, but I think we should explain it a little bit.
Absolutely. So initially, when Amarin, the company that was doing the REDUCE-IT trial, introduced this product and did some earlier studies as well, they needed a control substance, placebo, that looked like the fish oil, that had the same consistency as Eicosapenethyl, so that when patients were randomized, we had this blinded approach. And what happened is that they chose mineral oil, and mineral oil has been used for 50 years for constipation. It's been used clinically, it's been used in clinical trials. But when we finished the REDUCE-IT trial, we noticed a slight increase in inflammatory markers and a slight increase in LDL. So people were then saying, well, maybe the benefits not only EPA and Eicosapenethyl lowering risk, but maybe it's also mineral oil raising the risk. So I think the best evidence against that is twofold. I didn't show the slide, but I did a study of plaque because I used mineral oil as well in EVAPORATE because I didn't know about this effect when we started the trial. We looked at the rates of progression of plaque on mineral oil, and then we did it with a regular placebo, a cellulose-based placebo, and they were identical. There was no excess plaque progression by being on mineral oil. And the EMA in Europe and the FDA in the US say of the 26% event reduction, at most 3% could be attributed to mineral oil, and the rest would be attributed to the EPA. And I think the final piece of the puzzle is the RESPECT EPA trial. The RESPECT EPA trial, the secondary endpoint, had a 26% risk reduction for relative risk reduction. That's with pure EPA without mineral oil. REDUCE-IT had a 26% relative risk reduction using EPA, but with mineral oil. So if there is a mineral oil effect, it's very small. 3 out of the 4 outcome studies I showed you that were positive had no mineral oil, and 7 out of the 8 plaque trials that have been published did not use mineral oil. So we have consistent effects with or without mineral oil as the placebo. So I really think that this has been largely overblown. Unfortunately, it was mostly sour grapes from the people who were doing the strength trial. When their trial didn't work, they were trying to poke holes in the REDUCE-IT trial. But I think it's just EPA versus DHA. Strength was EPA and DHA, and REDUCE-IT was purified EPA. And I think that's the whole difference.
I think now that you said about the strength trial, the next question that keeps cropping up is the atrial fibrillation issue. There's about 1% increase in atrial fibrillation across the board in most of the EPA studies that were there. And when it is compared with placebo or mineral oil or whatever. And interestingly, the strength trial, though it did not have beneficial effects, also showed an increase in atrial fibrillation. So it produces the adverse effects without having the beneficial effects. So I think that was one point that these strength people should also remember about.
That's true. And they also had that mild bleeding effect that we saw with REDUCE-IT as well. So they had only adverse effects and no benefits if you use EPA plus DHA. And a thing that comes up in the United States a lot, questions are asked, can I just do this with diet? Can I just eat a lot of fish and get EPA? And the answer is you probably could, but to get the same levels of EPA, you'd have to have salmon 3 times a day, every day. You'd have to eat it for breakfast, lunch, and dinner to try to approximate the amount of EPA levels that you get from taking Eicosapenethyl 4 grams a day. So it would be almost impossible to sustain that over any period of time, and it would be very expensive, I think, to only eat salmon for every meal.
Actually, Jack did a publication on fish oil supplementation, EPA levels, and the EPA levels with these studies. And they found that when you take fish oil at that level, the levels don't come up, and they don't produce atrial fibrillation either. So the recommendation was that the question that was asked was, does fish oil supplementation in the form of dietary fish oil, does it produce atrial fibrillation? No, it didn't produce. So they were very clear about that. Though they said this may not be much of an effect of atrial fibrillation, they also said that fish oil can be taken because that is part of the recommendations. 2 servings per week is a recommended dietary fish oil supplement, dietary fish, salmon fish recommendation. That also
Absolutely.
is adding
and I continue to recommend fish for my patients, even if they're on Eicosapenethyl. And interestingly, AFib, the first time we saw that was a trial back in the 1990s called GISI Prevention, where they used 1 gram of fish of omega-3s, DHA, EPA, and they saw atrial fibrillation. So this atrial fibrillation story goes back many, many years now, decades, with fish oil, and there's some association of fish oil supplementation and atrial fibrillation. But I would remind everybody that while atrial fibrillation goes up, stroke goes down overall. So we're not invoking more risk in form of stroke, and sudden death goes down. So if you want to look from an arrhythmia standpoint for the electrophysiologists, less sudden cardiac death, less ventricular arrhythmias, even though atrial fibrillation goes up a small percent. So I don't worry about that too much, except I do avoid this in some of my patients who have paroxysmal AFib, especially if they have poorly controlled paroxysmal atrial fibrillation, because I just don't want to give them anything that may stimulate that. But other than that, I'm very comfortable using it, and it's wonderful in chronic AFib because there's no risk of new onset AFib if they already have it chronically.
Dr. Joshi, is there any questions on the chat?
Yeah, there is a question from the audience. Basically, there been one very interesting question. Whether this Eicosapenethyl, when combined with statin, can help prevent stroke recurrence.
Yeah, so there's excellent data for stroke, and patients with prior stroke were included in the study. We actually had a sub-study called REDUCE-IT Stroke that was published, and it showed it works to prevent new strokes and TIA. It also works in patients with existing strokes to prevent secondary strokes. Although the numbers were small in the REDUCE-IT trial, we've seen a consistent benefit across all 4 of the outcome studies with EPA. So we definitely advocated the diagnosis of ASCVD is coronary disease. They could have had a stent, a bypass, an MI, an acute coronary syndrome. It could have been cerebrovascular disease. They got into the trials with TIA or stroke, or they could have gotten in the trials with PAD, peripheral arterial disease, and all of those patients benefited independently.
Yeah. There's one more question from the audience. Sorry.
Even the REDUCE-IT trial, there was an 18% reduction in stroke. So even the primary trial itself had a reduction in fatal and non-fatal stroke reduction. So even that as an endpoint, it was a significantly positive trial. I think the sub-study that Professor Budoff is quoting is also a separate publication wherein it's used. Another interesting point with the entire REDUCE-IT trial that I thought I should make a mention, because only 70% had ASCVD, 30% are actually in the primary prevention cohort. Yeah. And even there in the primary prevention cohort, there was a significant benefit. There was not much of a difference between the 2 groups. Professor, I think I should make a mention about that as a very important point.
Yeah, absolutely. We've had a number of breakthroughs over the past decade, adding to statins, but almost exclusively in secondary prevention. Ezetimibe, PCSK9s demonstrated benefits, but only in secondary prevention cohorts. This, as you mentioned, had a similar benefit in the primary prevention cohort as in the secondary prevention cohort. So I do believe that this benefit extends beyond survivors of myocardial infarction or survivors of an ischemic stroke to implement therapy in those patients who have high burdens of atherosclerosis, as I showed in EVAPORATE. So we take patients with positive calcium scores or plaque in their arteries seen on a CT of some other body part. And we take patients who have primary prevention and multiple risk factors. And if their triglycerides are elevated, get them on Eicosapenethyl.
Actually, one of the study which basically has been published, where this Eicosapenethyl was compared with other triglyceride lowering agents like fenofibrate and clofibrate, not clofibrate, the nicotinic acid. What they have shown is, while Eicosapenethyl reduces the lipid peroxidation, the other lipid lowering agents do not have any effect on the lipid peroxidation. And this is perhaps, because of the high lipophilicity of the structure of the Eicosapenethyl. And basically, it is the space dimension being very small, it actually intercalates into the lipid bilayer of the atherosclerotic cell wall. And then basically the article says that it blocks the free radical propagation and prevents the lipid oxidation. And thus it exerts anti-inflammatory effect. It basically corrects the endothelial dysfunction and it prevents the cholesterol crystal domains formation. So how will you respond to this, Dr. Budoff?
Yes, so no, very important. There's multiple mechanistic benefits. I would encourage anybody who's really interested in a deep dive to listen to Preston Mason at one of his talks. He goes into a lot of these benefits of lipid peroxidation, of membrane stabilization, and literally has shown in vitro that the way that DHA inserts itself into the lipid membrane is not a stabilizing effect, whereas the way EPA inserts itself makes it antioxidant and anti-inflammatory, protecting the endothelium from Lp(a) and LDL from penetrating. So I think there's multiple biochemical, both in vitro and now multiple outcome studies and plaque studies demonstrating the consistent benefit of EPA across many platforms. And again, almost all of these studies, save two, did not use mineral oil. So I don't see that as a viable, reason to doubt any of this data.
So there is one more question from the audience that the patients who are on the maximum tolerated dose of statin, and if the doctor wants to basically add Eicosapenethyl, is it necessary to reduce the dose of statin?
Well, I think Dr. Prabhakar wanted to mention something as well. Maybe he can take that one.
I think what I was telling is beautifully explained in that Mason Preston article. The question that you asked is explained with a beautiful figure there, how the difference between DHA and EPA are there. I think it's a little too basic and very mechanistic, but I think, like Professor Mason said, it's an American Journal of Medicine. You can go ahead with that. The question about reducing the dose of statin, Professor.
Yeah, so I would say I typically do not reduce the dose of statin if they're tolerating it well. I believe that lower LDL is better, and I have to say I still, in my practice for these ASCVD patients and high risk primary prevention, I'm still obviously using a statin for the LDL, but now I'm also, if their triglycerides are still elevated after I start a high dose statin, I implement EPA, Eicosapenethyl, as my second drug to help treat the overall plaque as well as the triglyceride elevation that's persistent.
Having said that, sir, having said that, I want to add one more thing. See, there is no difference between the level of LDL, whether it is 70 or 100 or even less than 50. At whatever level of LDL and whatever level of even the triglycerides, this drug seems to be having a beneficial effect. The only condition in which there was to a point towards a placebo was when a low intensity statin was used. Otherwise, even with a moderate or a high intensity statin, across the board, it seems to be beneficial. In fact, what I would suggest is, I think this drug should probably be given for everybody. I think there seems to be significant benefits there across the board.
And I think most of us, especially those who don't eat a lot of fish and have, we know that we're not getting that fish intake. Obviously, this would be an excellent supplement in that setting as well. I agree.
So the extension of, as an extension to what Dr. Prabhakar you said, there is a question from the audience. Can Eicosapenethyl be given in acute coronary syndrome along with statin?
Yeah, can Eicospentethy be given with a
Yeah,
statin?
please.
Yes, of course. No, I use them together almost everybody. Obviously, if patients don't tolerate a statin, this is also a very nice adjunctive therapy for them. But I use them together almost exclusively.
But the omemethyl did not show much of benefit very early. And the question mark that I have here was, the benefits are always taking some time to show. Most of these, probably the earliest benefit is what Professor Budoff's trial, where he jumped the gun, and 9 months he started showing benefits in the CT scan. I think that is probably the earliest. Otherwise, all the trials take more than a year for the curves to separate, for all the curves to separate. So it seems to be a very long-standing effect, consistent effect, and the curves keep separating as the time goes by. So I think you don't expect immediate effects probably in an acute myocardial infarction. It's going to take some time.
Yeah, the significance was achieved in the ACS trial at 11 months for a statistical benefit. So that kind of correlated with my 9-month benefit seen in the EVAPORATE trial. So we do start seeing early and sustained benefits with Eicosapenethyl across the trials.
All right. And what about unstable angina?
Yep, no, so it had a profound effect, 37% reduction in hospitalizations secondary to unstable angina. That was one of our endpoints in the trial, in the 5-point MACE part of REDUCE-IT. So it definitely works to reduce unstable angina. And I think through all of those plaque stabilizing effects, that's a very large benefit of EPA.
Now, this is a very interesting question, whether 2 grams of Eicosapenethyl will have the same pharmacological benefit as that of 4 grams of Eicosapenethyl.
Yeah, so that's a great question. I think that the larger trials, the REDUCE-IT trial, the EVAPORATE trial, any trial done outside of Japan so far has demonstrated the need for 4 grams, and that's the dose that we try to use routinely in our practice. Having said that, the Japanese data did show benefits, slightly less benefits, but did show benefits with 2 grams. And I think that's consistent if you said, well, what about a low-dose statin versus a high-dose statin? Well, a low-dose statin invokes some benefit. A high-dose statin invokes more benefit. So I think high-dose EPA would be better than low-dose EPA, but 2 grams, but I don't have an exact head-to-head study to show you.
No, Professor Budoff group has actually done a study. I don't know who has done, who's the first author in that. He's the last author in that paper, where the amount of EPA directly correlated with the amount of plaque reduction, percentage atheroma volume reduction. So you have to go for a very high level of EPA, which is not possible. In fact, in the JELIS, the amount of EPA level achieved was more than the REDUCE-IT trial, but the benefit was a little less because their baseline levels were high. So we have to go for a very high increase in EPA levels to show this reduction. I think that's very important.
They are all fish eaters.
Yeah, so that's the reason why they had a high baseline value.
Exactly.
Yeah, no, they definitely started with a much higher level of serum EPA before the trial started in Japan.
So basically, essentially, Dr. Budoff, what you are suggesting, through this presentation, that the patients, who basically have high ASCVD risk, the patients who had previous MI, previous PCI, so the patients, this entire spectrum of the patients, can be benefited, if you could basically add Eicosapenethyl 4 gram along with the statin, that is the maximum tolerated dose of statin, because neither IPE should not be underdrugged, and even the rosuvastatin also should not be given at a low dose. Rosuvastatin should be given to the maximum tolerated dose, Eicosapenethyl 4 gram, and patients who have ASCVD risk or the equivalent of ASCVD risk, if the doctors want to prevent the first cardiovascular event, I think the best thing is, while you put the patient on rosuvastatin, also put along with that Eicosapenethyl. So this particular statement, do you think it's a very adventurous statement?
I do. I truly believe in almost everything we do in cardiology, maybe with the exception of aspirin, more is better, up to a limit at least. So high dose statin is better than low dose statin. For heart failure, we talk about achieving target doses of guideline directed medical therapy or GDMT for heart failure because it's better. We have low dose ACE inhibitor versus high dose ACE inhibitor studies that show high dose ACE inhibitors better than low dose ACE inhibitor for prevention of risk. And I think the same would be true with Eicosapenethyl. You get the 4 grams if they can tolerate it, which is very well tolerated. Patients like it because it's a natural therapy. It is derived from fish. It is goes through very careful steps of antioxidation and 7 steps of processing to get purified EPA. But it is a cured fish product, and therefore a lot of patients don't mind it because it's more natural as well. It's just supplementing their diet in a very regulated way to help them with their risk.
Yeah, so as you rightly said, Dr. Budoff, more the better. Could we extend this particular statement by saying earlier the better also?
I'm not sure I understand, Dr. Joshi. I'm sorry.
No, I mean, basically, yeah, Dr. Prabhakar, if you were to...
Mr. Joshi, see, the earlier the better has some basis. It is there in primary prevention also.
Exactly. So that was the reason.
That in the presentation that it should be better.
Yeah.
Now, what we presume as residual risk is what we have underplayed a lot. Now, if you look at the IMPROVE IT trial, which is the basis of the 50 and 55 LDL cholesterol lowering, because REDUCE-IT brought it down to 53. At 53 LDL cholesterol with the simvastatin and ezetimibe, the 6-year event rate was 32%.
Yeah.
Residual risk is significantly high. And if you're going to have an absolute risk reduction of nearly about 9% with Eicosapenethyl, I think that is going to be fantastic. And I think the benefit is going to be much more in a country like India, where I think the incidence of coronary artery disease is earlier, and we are 20 times more prone for heart disease than the Japanese. So I think we should give the fish oil. We don't give fish, at least the oil. I think we should give it in terms of Eicosapenethyl in India.
Yeah. As you said, Dr. Prabhakar, the reason why I basically said more the better, earlier the better, the reason being, as you know, that the Indian phenotypes, basically they have the onset of CAD 10 years earlier as compared to that of Caucasians. And even at the age of, before the age of 50, the fatality rate due to CAD is extremely high in India. And basically today, you see a lot of young patients, below the age of 30, 40, being found in cath lab, undergoing PCI in India. And 86% of the patients across the country, one of the survey has shown that regardless of the bias, whether the patient comes from the urban or rural, but there is at least, one dysregulation, at least, in one of the fraction of lipids, whether it is hypercholesterolemia, hypertriglyceridemia, low HDL, high LDL. But there is at least, so basically the dyslipidemic problem in India is extremely high. So
I think you're taking that point a little bit out of context. You're quoting the ICMR INDIAB data where 75% of the patients actually had a low HDL cholesterol. Now, HDL is not taken into consideration much, though the sweet spot for HDL today is 40 to 70. Less than 40 is harmful, more than 70 can become harmful. The curve starts going. There's a U-shaped curve for that. But looking at that, forget that, even if you forget that, if you look at the overall risk for India, 50% of the MIs and the acute events happen in age less than 50 years in India. This is much higher than anywhere in the world. So at that level, primary prevention becomes very important. And in primary prevention arm also, despite statins, there is a clear role for Eicosapenethyl in India. The second point is going to be in secondary prevention, the recurrent rates are higher. And there also Eicosapenethyl has been shown following ACS, following PCI, all arms. It reduces, it's probably the only trial that reduces the CABG and the urgent revascularizations. I think that is very, very important for India. And I think it's, if this drug is going to be available at a good price and it is going to be available all over India, the problem with India is we don't have the drug freely available here as yet. I think if we have that, I think we have an answer to at least reducing the 32% like the Improve it says to at least bring it down to another maybe about 10%. Professor Budoff, your ideas for India.
No, I agree. I think even in the United States, we consider a South Asian ancestry to be an increased risk factor by itself. So we're definitely more aggressive in this population. They have much higher levels of metabolic syndrome. So I think bringing this to India, getting this available to the highest risk population probably in the world for ASCVD is going to be very, very beneficial on multiple levels.
Actually, when Dr. Budoff was making a presentation and when he was showing the kind of clinical outcomes, for a moment, I thought, basically as if, this Eicosapenethyl has been specially made to meet the challenge of Indian phenotypes.
Yeah.
So, but I believe that
will work better. Yeah, it's overlapped so much with the Indian phenotype for sure.
Yeah. So I believe that, basically if Eicosapenethyl basically is used early on along with statins in the clinical practice, I think many cardiovascular events, can be either prevented or can be prolonged for a longer period of time. So I think, most of the questions, we have tackled, unless Dr. Prabhakar, you have something to add?
Sir, I think we should first of all thank Professor Budoff for an excellent overview of from the beginning to the end of Eicosapenethyl. I think he started off with the very early days, starting from the fish and getting into the fish oil and the complications thereof and the advantage of the complications. What we perceive as complications are actually the beneficial effects, clearly showing how they are going to be beneficial. And they are harmful. They'll increase the bleed, but no fatal bleeds. So that is probably the beneficial effect. And he made a lot of points about reduction in the sudden cardiac death, cardiac arrest. And I think the drug at 2 grams twice a day, how important it is to get the EPA levels to very high levels. And it has shown not only reduction in events, he's also showing reversal with the study in the EVAPORATE, which is actually, it seems to be slightly slowing down significantly the amount of atherosclerotic and atheroma volume. And I think the dose is very important. And I think this drug, I think, must be embraced by India very much. And I think once we start using it, I think we will be showing a significant reduction. And I'm sure once we get the drug, we are going to have some more studies coming out of India exclusively showing, complementing whatever Professor Budoff has done so far.
Yeah. And one of the slides, Dr. Prabhakar, which Dr. Budoff showed, if you basically see the comparison between Eicosapenethyl and placebo, he basically showed the hemorrhagic stroke, which is about 0.3% with Eicosapenethyl and 0.2 with placebo. So basically, I mean, is it statistically significant? Number one. Number two, bleeding. I think basically the risk the risk persists with Eicosapenethyl also and with placebo also. So basically, there is no particular difference. So I think one should not be unduly worried about AF, about the hemorrhagic stroke, about the bleeding, but the amount of the benefit and about the clinical advantages that Eicosapenethyl, which is going to provide to the patient, is I think where we need to focus on.
True, very true.
I completely agree. The net clinical benefit is very large in these trials, and the absolute benefit. We talk about a 1% increase in atrial fibrillation with no increase in associated stroke, but in the acute coronary syndrome patients, the absolute benefit was over 9%.
Yeah.
So even if you said dying is just as bad as developing AFib, you have a 9-to-1 benefit by putting them on EPA, on Eicosapenethyl.
The number needed to treat was just 11. That I think says it all.
Exactly.
Just 11 patients.
Exactly.
I think that's very important. Professor Budoff, your summary of whatever you have said so far. What are your last final words of wisdom for us?
Yeah, so I would say that I think that this field is becoming much clearer, that we now are starting to understand why even the Mediterranean diets and places that have high fish intakes have less cardiovascular events than some of the other regions of the world. And some of this is going to be related to the beneficial effects of EPA. But to really achieve the doses that we benefit the most from, especially in high risk primary prevention or in established ASCVD, we really need to think about supplementation in this high risk cohort. And I use it regularly, and my patients really appreciate it. It's well tolerated. And the benefits are quite large, as you mentioned. In some of the subgroups, a number needed to treat as low as 11 for a product that's derived from purified fish is just remarkable.
I think Dr. Budoff has summarized it very well, and Dr. Prabhakar also has summarized the entire presentation in a very excellent manner. So Dr. Budoff and Dr. Prabhakar, thank you so much once again for joining us today for this webinar. There are a number of doctors who have basically joined this webinar. A lot of questions came, but since some of the questions were answered in your presentations itself, I did not repeat those particular questions, but I'm very sure that your presentation and the interaction with Dr. Prabhakar have greatly benefited the Indian doctors here. And I'm very sure that when this Eicosapenethyl is made available in the Indian market, there are going to be a lot of doctors, who are going to start using it early on, and along with statin. And as you rightly said, that the maximum tolerated dose of statin and 4 grams of IPE is basically the combination, and that is ultimately going to benefit the large number of patients. So thank you very much, Dr. Budoff. We were greatly benefited, and we enjoyed your presentation. It was very enlightening. Dr. Prabhakar, thank you so much, because unless these kind of intellectual interactions happen with the international faculty of the stature of Dr. Budoff, the jewels of wisdom cannot come out. So thank you so much, Dr. Prabhakar, to you also. And Dr. Budoff, it is so tempting now to basically invite you again. To when this Eicosapenethyl is made available, and we look forward to it, and I'm sure that you will not disappoint us.
It's been an honor. Thank you very much. It's been great to interact.
Pleasure and honor
you and Dr. Prabhakar.
Yeah. Thank you so much, sir. It is a pleasure and honor for all of us to learn from you, sir. Thank you so much.
Yeah, thank you so much to both of you. Thanks, and thank you so much to all the entire audience for joining us today for this webinar. And I wish all of you very pleasant evening ahead. Thank you very much, and I wish you all good night. Thank you very much.
Good night, Professor.
Thank you, sir.
Right. Thanks, Mr.